Hello and welcome everyone. Thanks for joining us for today's training on assisting newcomers with navigating the U.S. health systems, which is an introduction for direct service providers. My name is Tigis Coleman and I'm the Senior Training Officer with Switchboard, and I'll be your facilitator for today. I am joined by my colleague, Rosalie Arendt, who is behind the scene assisting with technology and logistics. The training is presented to you by Switchboard in collaboration with Minnesota Center for Excellence in Newcomer Health and National Resource Center for Refugees, Immigrants, and Migrants, which is also known as NRC-RIM. I want to direct you to the chat box where we've put a link and brief information on Switchboard, Center for Excellence in Newcomers Health, and NRC-RIM. I'd like to start with a quick overview of our setting in Zoom. This is a Zoom webinar, therefore you're joining on listen-only mode. Due to the very large size of the webinar today, we have disabled the chat box. However, you do have the option to send messages to the speakers and panelists. Keep an eye out on the chat for messages from Switchboard with links to various resources that we're going to be mentioning throughout. And given the amount of information that we're covering, we encourage you that you type your questions in the Q&A box throughout the training. You can click the thumbs up to upvote for another participant's question. And we have experts from Office of Refugee Resettlement and NRC-RIM who will answer your questions in the Q&A box throughout the session. The main speakers will also have some time at the end to address any information or questions that you might need. Lastly, I'd like to mention that today's session will run for 1 hour and 30 minutes, and that is being recorded. You will receive an email with the recording, the slides, and the recommended resources within 24 hours. And the webinar's transcripts will be posted on the Switchboard website within a few days, since it takes some time to complete as they must comply with web and accessibility standards. With that, I am delighted to introduce you to our speakers and panelists today. We have Dr. Mary Fabio, who is a Children's Hospital of Philadelphia, which is also called CHOP, pediatrician and a director of the CHOP Refugee Health Program, which she co-founded. She's a clinical assistant professor of pediatrics at the University of Pennsylvania, and she's an attending physician in the CHOP Care Network. We also have Marc Altshuler, who's a professor of family and community medicine and residency and director for the Thomas Jefferson University Center for Refugee and Immigrant Health. As the largest single provider for refugees in the city, he also co-founded the Philadelphia Refugee Health Collaborative, which brought together 3 existing refugee resettlement agencies. We also have Ariel Ressler MacNeill, who serves as the Senior Manager of Health, Access, and Specialized Support at Nationalities Service Center. In her role, Ariel oversees health, programming, and on-site food pantry. She also coordinates the Philadelphia Refugee Health Collaborative, which is a collaboration of area resettlement agencies and refugee clinic partners. We have Blain Mamo, who is the Refugee Health Coordinator at the Minnesota Department of Health. She oversees the planning, the coordination, and implementation of the statewide refugee screening program. She's also the principal investigator of Minnesota Center of Excellence and Newcomers Health activities. As we mentioned, we have additional panelists who will be answering questions throughout the training. We're thrilled to have Ssi Young and Kaleli Petsy, who are both senior program specialists in the Division of Refugee Health at Office of Refugee Resettlement. Ssi and Kalela work on refugee medical assistance and medical screening policy and program operations. They're both available via Q&A function to answer any refugee medical assistance and medical screening questions. We want to note that Office of Refugee Resettlement does not administer the Medicaid program. However, Ssi and Kalela can help answer some basic Medicaid program questions you might have. Last but not least, we have Sarah Clark, who's the technical advisor for health promotions with the International Rescue Committee. And she's the coordinator of the Society of Refugee Healthcare Providers. She's a global health professional who specializes in refugee health and resettlement. All right, so the learning objectives that we have for you is that by the end of this session, you will be able to describe U.S. healthcare coverage options and health-related benefits available to newcomers, including refugee medical assistance, Medicaid, and others. We also hope that you can name some key U.S. health services available to newcomers, including domestic medical screening, primary care, and others. Now, we recognize that we only have 90 minutes today and that we won't be able to talk about every program and services. Therefore, we focus just on a select that we think are most relevant. With that, give me 1 second. We'll get us started with a quick interactive, there we go. With a quick interactive feature called Slido, we recognize that we have a lot of people with different backgrounds and experiences. Therefore, we would like to get an idea of the different positions and specialists represented in the group. So if you have the ability to take the survey, please, and I see lots of people already doing that, please take your phone and scan the QR code, or you can go to any internet browser and go to slido.com and enter the code you see on your screen. Great, glad that it's all working. Wonderful, I'm just gonna give it 10 more seconds or so, but I'm seeing that there's about 75 of you, or 70% are from resettlement agencies or affiliates. Great, this is great, and I think it gives us an idea of who's in the audience. Thanks so much for your participation. With that, I would like to hand it over to Ariel to get us started.
Hello, everyone. Great to be with you today. I'm going to start us off talking about U.S. healthcare coverage and benefits. So we'll talk about different options that are available to newcomers. Sorry, hit the wrong thing. First, I have a few questions for you. So some more interactive questions. So the first one is, Medicaid by itself typically covers all medical services that newcomers may want or need. True or false? We'll give you some time to answer that. All right, I see more false than true right now, but it looks like someone on both. So it would maybe seem logical that it would cover everything, but Medicaid services vary state to state. And we'll talk a little more about that, some things are covered in every state, but then others aren't. And it may not cover all services that people may need. So thanks for participating for that one. The next question is, refugees, asylees, and special immigrant visa recipients are eligible for supplemental security income, or SSI, benefits. Is that true or false? And it looks like we have some folks who are familiar with SSI. We will be covering that briefly, the eligibility for that. So yes, it is true that refugees, asylees, and special immigrant visa recipients are eligible by their immigration status for SSI. Of course, there are some other eligibility categories that people need to meet to be eligible. All right, thanks for your participation. So moving on to just some basic health insurance coverage terms. So these are terms that you may be familiar with from your own personal experiences with health insurance, or maybe not, but they do apply to, if you have employer-sponsored health insurance, they certainly apply there too, although we're not really going to talk about, that type of insurance. But some of these terms first we're going to talk about a premium. So a premium is what most health insurances require you to pay every month in order to be a member and have access to their services. In addition to a premium, most insurances require a deductible. So the deductible is the amount that you pay for covered health services before your insurance plan starts to pay. So, one example is if you have a $2,000 deductible, you pay the first $2,000 of covered services yourself, and then your insurance starts to kick in. And after you've paid the deductible, your healthcare coverage may pay a portion of the cost. So that's where coinsurance comes in. So, typically they would pay a portion of the covered services. So let's say 80% maybe, and then, you as the consumer would be responsible for the other 20%. So that's what coinsurance is. And then lastly, every time someone goes to the doctor or has a test or procedure or gets a medication, there's typically a fee associated with that. So we usually call that a copayment or copay. And that's, maybe the one that's most relevant for those on Medicaid. There's sometimes a small copay, but that's something that varies as well. But let's say your health insurance plan's allowable cost for a doctor's visit is $100. And your copay as the consumer, as the patient, is $20. So if you've met your deductible, then you'll pay $20. If you haven't met your deductible, you'll pay the full amount, the $100. And you can find more information on these terms at www.healthcare.gov/glossary. So let's talk about Medicaid. This is kind of the most common coverage for many newcomers, including refugees and special immigrant visa holders typically. So Medicaid is an insurance program that provides free or low-cost health coverage to some low-income people, families and children, pregnant women, the elderly, and people with disabilities. So many states expanded their Medicaid programs to cover all people below certain income levels, but not all states. And whether you qualify for for Medicaid coverage depends partly on whether your state has expanded its program. And Medicaid benefits and program names vary somewhat between states. So I'll just be talking about very general information, but it's definitely a good idea to check what is covered in your state and with different managed care organizations in Medicaid in your state. But different program names, that can be a little confusing. So for example, in Pennsylvania, it's called Medical Assistance. That is Medicaid, but may have different names in other places. And Medicaid eligibility is determined by the local public assistance office. So under APA and RMP compliance, a Medicaid application should be completed within the first 30 calendar days. So it's done at the same time when clients apply for other benefits. In some states, Medicaid approval is taking a long time. So it's another thing that really varies state to state, or even, I would say, office to office, region to region. So for example, in where I am in Philadelphia, our resettlement agency case manager will typically help a newly arrived client to apply for, for Medicaid and other public benefits within the first few days after arrival. And they can do that by going in person with them to the county assistance office, or sometimes just by communicating with a caseworker. And we actually have a refugee unit at the county assistance office, one of them in Philadelphia, that helps us to kind of expedite this process. But again, that really varies place to place. And then once we have their recipient ID numbers, we can complete the registration process with our partner refugee clinics, those providers. So next we will talk about what does Medicaid cover. As I said, this varies, but there are some things that Medicaid covers in all states. And that's because the federal government requires that Medicaid pay for certain things regardless of the state that people live in. So those things include hospital visits, doctor visits, labs, and x-rays. Many other things such as dental care, eye care, including glasses, prescription medicine, family planning, really depends on the state. So one example is that in Pennsylvania, Medicaid coverage is for glasses for kids, but not for adults. So it can, just vary based on the rules there in the state. So, and often state Medicaid programs will partner with groups called managed care organizations, or MCOs, to provide some of these extra benefits. So we'll talk some about how to help clients select an MCO later on. But each MCO will provide different coverage and benefits. Some examples are maybe some are especially good at providing interpretation for doctor's appointments that you can schedule ahead. or maybe some have more dental coverage, just some examples there. So now I'm going to talk about refugee medical assistance. So this is administered by the Office of Refugee Resettlement, or ORR. It provides short-term medical coverage to refugees who are ineligible for Medicaid. And the benefits are generally similar to Medicaid and administered in most states by state Medicaid programs. And in addition to providing access to healthcare, RMA funds enable clients to receive domestic medical screening upon arrival in the US, and we'll certainly be talking about that screening more in detail in a later part of this training. And clients whose date of eligibility for ORR benefits that is on or after October 1st, 2021, have an eligibility period of 12 months for RMA. So that's a change from previously, so something to note. Next slide, please. I'm also going to talk about supplemental security income, since that was mentioned earlier. So this isn't really healthcare coverage as in insurance, but it's an important benefit that people may be eligible for, so important to talk about. So Ssdi is a program that provides monthly payments to adults and children who have low income and resources and who are blind or have a disability. So in most in most states, people eligible for SSI are also automatically eligible for Medicaid. In other states, people must complete separate applications. So one really important thing to note is that a person is not required to have prior work or employment history in the US to be eligible for SSI. So that's different from Ssdi, and I'll talk a little more about that later. But applying for SSI can be a long and complicated process. So that's usually something that is good to prepare your client for if you're helping them apply, that it may not be a quick and easy thing. It may be a long process. And each SSI case is examined by a board of medical providers who make their decision based on information they have gathered from the person, from their medical providers, and sometimes from other doctors that they consult with. So that's part of why it can be a long process. And many times a client's first SSI claim is denied. In this case, the decision may be appealed. The one area or one situation in which it is actually relatively straightforward to apply for SSI is for clients who are age 65 and older. They're usually approved quickly. Proving a disability can be more difficult. Adults must be unable to work due to a physical or mental impairment, which has lasted or is expected to last at least a year, or is expected to result in death. And for children, they must have a physical or mental impairment, which results in marked and severe functional limitations. Impairments must also be expected to last for at least a year or result in death. So I am going to list just a few conditions that are kind of more likely to be approved, or maybe ones that you would, if you know that it's a condition that applies to your client, you would be thinking about SSI and applying. So one is deafness that can't be improved with hearing aids. Another is blindness, Down syndrome, major amputations, immobility, which is a little vague, and other medical conditions that would be assessed on a case-by-case basis. Next we'll talk about Ssi Compassionate Allowances. This is important to note for any clients that have been diagnosed with a terminal illness, that it is really important to apply for SSI as soon as possible. So you would indicate on the SSI application that the condition is expected to result in death and call the number listed here, the Social Security Administration, to make an appointment for an interview, and they may be able to expedite the application process. Wanted to make a note of that. And now for another health insurance option. So for some populations, they may not be eligible for Medicaid. So this includes VAWA petitioners, those petitioning for immigration status under the Violence Against Women Act, and also asylum seekers with employment authorization. So they're not eligible for Medicaid, but they can get a plan on the marketplace. So kind of the insurance exchange that was set up, originally through the Affordable Care Act. And, these plans are, the cost is income based because there are tax credits available for qualifying individuals based on their income, and that those tax credits really help to lower monthly premiums. So that's something to note. And I know, for us at my resettlement agency, for our clients, often it's folks who are maybe a single person in the household. So they're just providing for themselves and they have a really steady, well-paid job. Then they may make too much to qualify for Medicaid. And this marketplace insurance is a really good option. So some states use their own federal marketplace, use the federal marketplace, some use their own state exchange. So I'm always talking about Pennsylvania because that's where I'm from, but the state exchange in Pennsylvania is Penny, for example. And this, application process is kind of similar to, with insurance through an employer in that you need to have a special enrollment period to be able to enroll, unless it's during the open enrollment period that happens typically in the fall around November. But a special enrollment period happens for 60 days after someone gets their immigration status, or after loss of other coverage or other eligible life change, such as if someone has a baby and wants to put them on their plan, or gets married and a spouse is enrolling on the plan. Okay, so I'm just going to kind of summarize different coverage options. So we've talked about Medicaid, which is the free or low cost coverage for specified populations, and is different in different states. Some states expanded Medicaid to cover all people below certain income levels. And also CHIP is listed there. That's the Children's Health Insurance Program, because that provides low cost health coverage to children and families that earn too much money to qualify for Medicaid, but not really enough to buy private insurance. So that covers kids. And then in some states, it also covers pregnant women. And then we also have RMA, or Refugee Medical Assistance. So that's short-term medical coverage for some newcomer populations who are ineligible for Medicaid. And then supplemental security income, those monthly payments to low-income adults and children who are blind or disabled. And I'll just mention a little more here about Ssdi, Social Security Disability Insurance. So that's the one where people do need to have a qualifying work history. For SSI, people do not need that work history. So most of our newcomer clients that we're working with will not qualify for Ssdi. But some people use those terms interchangeably, SSI, Ssdi, so it's important to know that difference. And with qualified health plans, those are the insurance plans certified by the Health Insurance Marketplace, so they meet the standards of the Affordable Care Act. So some of the things that they are required to cover are pre-existing conditions. They need to follow cost sharing limits, and they need to provide certain essential benefits. And interestingly, the marketplace can also be used to find out if you qualify for Medicaid or the Children's Health Insurance Program. So just a note there. And then there are other public programs. I talked about Ssdi already, but there are some state-specific programs as well. So that is something to look into in your own state. So the top health coverage takeaways, I think I've said several times that things vary state by state, and also depending on a client's immigration status, what they may be eligible for. So be aware of that. One example that I have listed here is dental coverage, because that's a big one that has come up with our clients time and time again. In Pennsylvania, Medicaid covers more dental care for children than for adults. So, there may be differences there. Another kind of takeaway is to establish resource mapping for service providers in your community who have experience working with refugees, immigrants, and other newcomers, and, establish connections, establish relationships with them, really try to work closely with them in a collaborative way. That can be a really effective way to help your newcomer clients access really high quality healthcare. And then if I saw that, many attendees at this webinar are from resettlement agencies. So if you're kind of acting in that capacity of either resettlement case manager, or if your agency has kind of health specific staff, and you're one of them, your role is really as a health navigator to teach and provide tools, help people know how to navigate the really confusing US healthcare system, and really kind of teaching that process and those tools, and rather than kind of scheduling and managing everything, try to teach those skills. So I'm going to talk about our case scenario that we'll be revisiting in later parts of the webinar. So I'll just read it first. Emil is a client from the Democratic Republic of Congo, or DRC, who has been in the US for 2 weeks. He arrived together with his wife, Anifa, their 2 young children, Lido, age 3, and Gloria, age 14, and his elderly mother, Marie. So imagine you are this family's assigned resettlement agency caseworker, and that may actually be, your job for many of you. But if it's not, just imagine that's your role. So how might you help this family within the first few weeks of their arrival? And we'll answer that on a Slido. All right, so we have some responses already. I see apply for Medicaid is big, which is great because that's what we've been talking about. So I'm glad that point hit home. School, looks like school enrollment is important. Health insurance, yep. I see a lot of different things on here, and I think that's a really good point to make too, that there are kind of a lot of things that people, may be thinking about or maybe, need support with in their first few weeks and months after arrival. So, it's definitely a big picture. But some of the health related other things to think about here are, kind of besides the basic documents of social security number, state ID, what you all said about applying for health insurance, specifically Medicaid typically, and scheduling the initial refugee health clinic appointment, and establishing a PCP, primary care provider for all the people in the family. So in my context in Philadelphia, that's the same as the refugee health screening. So, because we're working with these clinic partners, some of whom are my fellow panelists, they, that establishing that care at that first refugee health screening appointment, that's where they first establish care, but then they continue, with that provider, that provider office as their primary care provider moving forward. And you all mentioned, school enrollment, so certainly immunizations for everyone, both related to school enrollment for the kids and just generally. And I'll turn things over to Blain Mamo now.
Thank you so much, Ariel. Hi, everyone. I will take a few minutes to highlight some key partners in newcomer health. As you all know, partnerships in refugee resettlement are critical, and our shared vision for all partners involved in newcomer health is really to optimize and make sure that our newcomers are healthy and have a safe environment that they're moving into. As partners, we leverage our resources and expertise and do a lot of problem solving to effectively help refugees access healthcare services. So I'm going to start with our federal partners and walk you through the agency's specific roles through the newcomers' migration and health-related journeys. And as a reminder to everyone, and most of you know this, refugees undergo 3 exams. There's the overseas or the pre-departure medical exam, the domestic medical screening, and then the adjustment of status exam that happens about a year after they've lived in the US. So I'll start with the State Department, Bureau of Population, Refugees, and Migration. They oversee the newcomers' overseas medical exam, and it has delegated the International Office of Migration to complete these pre-departure medical screenings. Once these exams are completed and the refugees are assured to travel to the US, the medical records, such as the biodata, the special medical forms are transmitted to you, the resettlement agencies, via the State Department. And then you take that information then to start planning for the refugee screenings here domestically as part of your reception and placement services. The Centers for Disease Control and Prevention, those are the clinical and public health experts. The CDC provides technical instructions to the panel physicians, and the panel physicians are really designated healthcare providers who complete the overseas medical exams. And then on the domestic side, the CDC publishes the domestic refugee health screening guidance that our local providers use to conduct the refugee screenings here. And then after the newcomers have entered the US, the Centers for Disease Control and Prevention electronically transfers up-to-date medical records, including some pre-departure medical forms, to us, the state refugee health coordinators, or the healthcare providers who have access to CDC's electronic disease notification system. It's a database that we all kind of go in, check regularly to download all the medical records. We review those records and forward them to the clinicians on the ground. The CDC also supports our Centers of Excellence as well as NRC RIM to make sure that we offer relevant training, tools, and resources to healthcare professionals and new service providers who serve all the newcomers coming in the US. And third is the Office of Refugee Resettlement. They issue policy and direction on all aspects of refugee resettlement in the US. So as such, what they do is they allocate critical resources to state refugee and refugee health programs and the service providers across the state to ensure comprehensive medical screenings. And we also conduct health promotion activities for newcomers. ORR's programs are designed to meet the basic needs of newcomers. And we all know the importance of a really healthy beginning for newcomers as they start their new lives here. And lastly, when refugees adjust their visa to become permanent residents, they do complete the immigration medical exam. That is a requirement for the adjustment of status. And for most refugees, the only requirement is to be current on their age-appropriate immunization. So we, at the state level, we really work hard with service providers on the ground to encourage newcomers to complete their immunizations, including their required COVID vaccination, which is a new component of that immigration exam. And we want that to be completed during the refugee health screenings domestically. I definitely would like to note here that immigration medical exam requirements for various ORR benefit eligible populations vary. So it's really important for newcomers to check and work with immigration law specialists or civil surgeons to make sure they're following the requirement for their visa type. Next slide, please. Next, I'll talk about state refugee health programs. So I'm a state coordinator, a refugee health coordinator here in Minnesota. And I want to say that the placement, the structure, and capacity of refugee health programs vary by state. However, generally our offices coordinate the domestic health screenings with refugees and other ORR benefits eligible populations. We conduct data collection and may assist with disease surveillance, especially if we're located in a health department such as we are here in Minnesota. We also facilitate data transfers to state immunization registries so that healthcare providers and school nurses can easily locate the most current vaccination records for newcomers. We also provide lots of technical assistance and training to healthcare providers doing the refugee screenings. We also engage with all of you to conduct health orientation and promotion activities. And we really facilitate communication between resettlement agencies, healthcare providers, and local public health to improve healthcare access and services for refugees. So as service providers, we really recommend you connect with your state refugee health coordinator regularly to coordinate the screenings, to consult on clinic capacities, especially if you're in a smaller community. It's really important to know what's out there so that you can advocate for better services. So you can partner with the state's refugee health programs, with local public health, with your providers to really advocate for services for your newcomers that you're serving. Please know that we are working very closely with our federal partners to improve our processes, our programs. We exchange important information on emerging health issues and public health updates that we share with our resettlement agencies and other service providers on the ground. Next slide, please. Next, I'll just spend a little bit of time talking about local health department and community-based or private healthcare systems, including FQHCs that you're probably all working with. Depending on your state, county or city health departments may coordinate health screenings in their respective jurisdictions, and they may in fact have their own public health clinics or TB clinics or immunization clinics that newcomers can easily access. And these local public health agencies may be able to also sign off on that I-693 form, which is the immigration and medical exam form, if they have a medical director on site or if they have capacity to offer such services. So it's always good to know what services are available at your local public health agencies. And our clinicians, our champions, they are the healthcare professionals, who are very familiar with the refugee health screening guidance and our experience with working with refugees and immigrants. And after, their screening, they can also facilitate connection to other services. And I would let Mary and Marc talk more about their role in the clinic setting there. Next slide, please. So we're back at the case scenario. So just to remind you, this is a Congolese family, Emile and his wife Anifa and the 2 children and his elderly mother. And so as a caseworker, imagine you're reviewing the medical records that you receive and you see noted that Marie has diabetes. And so I have 2 questions for you. One is, if you were this family's assigned caseworker, what considerations or actions would you take for Marie? And then the second question is broader. It's, in what ways are you connected with your state's refugee health coordinator, your local health coordinator, or refugee screening clinic? So get your QR code reader ready, and we'll go to the next slide. So question again is, what would you do for Marie? I have to smile at some of the answers there. I do like, assess insulin supply, medication. Do they have enough medication? Just assess general well-being. And one thing we definitely want to do here is consult, right, with your providers and see if they can get in. And if there's a way to expedite that Medicaid, definitely do that. Yep, update the refugee healthcare provider. Yeah, I think you got this. Yeah, transportation is huge. I'm glad you're bringing that up. You want to make sure that they have adequate transportation to get to their clinic. Yes, and if you have that relationship with the provider, you can even share the medical records. Typically, state refugee health coordinators also share that information, or the newcomers themselves may have their medical records with them. So encourage them to bring that to the clinic as well. Yes. So I think you've, just to summarize, you want to check medication supply, make appointment with our PCP, apply for Medicaid. And we'll go to the next question. So, in what ways are you connected with your refugee health coordinator, local health coordinator, or refugee screening clinic? So imagine this family and you need to consult. Are you connected? And what other ways are you connected with? What do you do in your location? And if you are a state refugee health coordinator or local health coordinator or a clinician, how are you connected with the resettlement agencies? Yep, we recommend, of course, submitting the referral is key. Having regular check-ins with your partners is super important, because together you can even train healthcare professionals. You can train local communities about the newcomers, and work together on mapping resources and services. You can problem solve together. This is a team effort for sure. Well, thank you so much for participating here. I'm going to hand this over to Mary. Thanks, everyone.
Great, thank you so much, Blain. All right, I'm going to switch a little bit because I am the medical provider, and so I'm going to focus a little bit more on the medical screenings for some of the newcomers. And the first thing I think that's really important is getting a domestic medical screening. What exactly does that entail? That is a very comprehensive medical examination. We're screening newcomers for infectious diseases, non-communicable conditions, assessing their health history, and talking a lot about the things that they may have been exposed to in the refugee, in their journey, in their resettlement. So it's really an examination, and we're focusing a lot at that initial domestic medical screening on things that could be problematic or could be infection risks for people in the area where they are resettling. So we're looking at tuberculosis and hepatitis and a lot of other diseases. So that is one of the things that we're doing in the domestic medical screening examination. There are very excellent guidelines on the CDC website. It's the cdc.gov Immigrant and Refugee Health, and we'll drop that information in the chat for you. But there is very excellent domestic medical screening guidance for providers. And this is a time where we really talk to them about their health issues. We try to identify any problems that they may have had. Some of the refugees and immigrants that we see have never had a comprehensive medical examination. They have not been spoken to about routine health care and well-being, wellness, preventive care. So we really try to introduce them to the US healthcare system and talk about the importance of getting their medical screenings, getting their vaccinations, and identify any issues that may need referrals for specialty care. Most times the domestic medical exam is recommended to take place within the first 90 days of arrival. We really try to partner with the resettlement agency to get people in within 30 days. It's really important to do that so that families can get their children in school. So if they have any medication needs, we address those. We do vaccinations. So a lot of that is done in that initial domestic medical screening. Next slide. In our office, many places do domestic medical screenings and then they refer to somewhere else for primary care. We try to keep that all in one location. So we do the domestic medical examination, and then we also usually take those patients as our primary care patients. So this helps us with the 4 C's of primary care. So we are the first contact. We try to really do comprehensive medical care, asking about going all the way back, especially for children. Some of them may not have had, newborn screenings like we do in the United States. They may not have had a complete physical examination. They may not have had their hearing or their vision checked. So we try to do all that. We try to coordinate any specialty care that they may need, and we really like continuity. So we like them to come back and follow up with us. Primary care providers can be doctors, nurses, nurse practitioners, PAs. We try to maintain long-term relationships with the patients. We are their primary care providers, or PCPs. That is a very, very important relationship that we try to build and build trust with families. Some of the refugees that are coming in haven't had a relationship with a medical provider, and may be a little bit suspicious or may not want to talk about all of their health problems. So we really work on relationship building with the families. And, one of the things that really helps us that is having good interpreter services and making sure that we are listening to the families and trying to provide care in a culturally appropriate manner. Next slide. Specialty care is if they need higher level care, if they have a medical problem, say they have hearing loss, or they have a murmur that we appreciate and they've never been seen by a cardiologist, or they have a skin condition that needs higher level care. So those types of things, often the primary care provider will identify that problem, and then we do a referral. We'll suggest where they should go for more, for additional care. And we'll facilitate that and try to get them to somebody for that specialty problem, and then follow up and make sure that they went. Often the resettlement agencies will help schedule those specialty visits. So we really like partnering with the resettlement agencies and letting them know what things we've identified and who we recommend that our families see. Next slide, please. We're going to go back to our case scenario. And as we know, it's a family from DRC. They've been in the US for only 2 weeks, and they're coming to see their primary care, their PCP. So Lido and Gloria are accompanied by their parents. These are the children who are 3 and 14. And they're coming to their initial clinic visit to establish a PCP, and they're going to meet me. I'm Dr. Fabio. I'm a new doctor in the clinic, and I don't have any experience working with refugees. Emil and Anifa have no medical records for their children. They know they got vaccinations during the overseas medical exam, and they say they got vaccinations. They may have gotten some vaccinations in DRC, but they don't remember. So how do we access the OME information? And OME is the Overseas Medical Examination. I like the no idea. So perfect. So connecting with your state refugee health coordinator is excellent. EDN is the electronic disease notification. And if you have access to that EDN, that is incredibly helpful for getting the overseas medical examination. Speaking with the resettlement agency, often they have a copy of the overseas medical examination that they can share with the medical provider who's going to be seeing the patients. So great, I'm seeing lots of things, a lot of I don't knows and a lot of connections, which is wonderful. So the one thing I will say about the electronic disease notification is the CDC, right, the IOM bag is another place where you can get that. That's the International Organization for Migration. And a lot of times families will bring those IOM bags. And so that's really a great thing. And they will have often a copy of their records in that bag. Sometimes they even have brought vaccination records from their home country. So I always ask what records they may have. And I try to get the overseas medical examination. I can log into EDN, and I can talk a little bit more about how you can get access to EDN. So the other question is, what considerations might you have for Dr. Fabio while working with Lido, Gloria, and their parents? Yes, be gentle, they're scared, which is like so true and amazing. Making sure you have an interpreter for the correct language. Just an example today, I saw a family today, and the primary language was Kirundi. So I had a Kirundi interpreter, but the children actually had not been born in Burundi. They had been born in Zambia, and they didn't speak Kirundi. They spoke Inje and some English. So having the Kirundi interpreter for the children was not helpful. And they were 3 and 4 years old, and they were scared. So always really important to find out what languages the parents speak, the children, and how we can best facilitate communication. Great. I see a lot of empathy, language line, using an interpreter, work slowly. Exactly. Religious accommodations, so many different things, and cultural awareness. I mean, I love to say that I'm culturally aware, but for each family that you work with, it may be different. And I can learn a lot about one culture, but I always have more to learn. And I think being humble and understanding that it's very difficult to understand where people, the whole story and where people are coming from. So, okay, next slide. All righty. So considerations to share with medical providers. So I think really important is if the medical provider is not familiar with the medical screening, there's many resources that are available for clinicians. One of the things that's an excellent reference is the CareRef recommendations, and that talks about, you can log into that site. It's a CareRef, and they'll drop that reference into the chat, I believe, or it'll be on the slides. You can put in the country of origin or departure and put in the ages of the people, and it will provide you with recommendations for screenings. CDC has a lot of recommendations also. So the CDC guidance for the domestic medical exam, as I've mentioned before, getting the overseas medical information. And really important when you're looking at the overseas medical information, right prior to departure, most families who are being resettled through the regular resettlement channels, that this would be different for the Ukrainians and the Afghans who came in a very disorganized fashion. Most of those people have had an overseas medical examination where they have most likely gotten some vaccinations, at least the children, and have gotten pre-departure treatment for specific parasitic infections or malaria. So it's important to go into the most recent EDN and get those things, because if you're accessing an overseas medical examination from a month before they resettled, it may not have their pre-departure treatment on that. And that can really help when you're evaluating them. Really important for this case that we have, the older child is 14. Most people are not familiar with the US confidentiality for adolescents. So trying to explain that, trying to understand that adolescents have some confidential, they can speak to their medical provider on their own. Now, obviously, I don't necessarily bring this up in the first, do that during the first visit, because the first visit is usually long and it may be overwhelming for families, but sort of planting that seed and letting them know that we will speak to the teenager alone, and they have the right to confidential medical care. Making sure that you have appropriate language access is critical, and giving some expectations for yourself and understanding that sometimes you may be seeing a family with multiple children. It can be a little bit overwhelming. A visit with an interpreter takes at least double the time as a visit without an interpreter, and to realize that you may not meet every single medical need that they have at the very first visit, but that you can schedule a follow-up. And continuity is important in these cases to make sure that you're addressing things over time and try to address the most important medical problems at the very first visits. Next slide.
All right. Here we go. Sorry about that. We just want to take a minute for you guys to have a break. I think my slide advanced a little too fast and threw me off, but let's give you guys a minute to get hydrated, stretch, or attend to yourself, and we'll be back in just 60 seconds. Thank you. Wonderful. Thank you all. We're back and would like to take this time to hand it over to Dr. Marc Altshuler, who is going to get us through the next section. Over to you.
Great. Thank you so much. Hi, everyone. Mary did a phenomenal job reviewing some of what we do as primary care physicians. And, obviously, I think for newcomers, it's no surprise that it's very overwhelming when they get here, and there's a lot of new information that they need to learn about. And a big portion of that is really kind of understanding a little bit about the healthcare system, how it works here, and when to access certain services. And certainly as primary care physicians, Mary and myself, as well as many others, we definitely bring this up a lot during our visits and explain to our patients based on their medical conditions, when they should be coming back, when if something happens, they go to the emergency room. But it's also something that we encourage our refugee resettlement partners to also discuss in some of the orientations that occur, because it is very important for them to understand how to access medical care, because for the majority of them, the care in the United States is very different than what they had at home. So Mary already kind of discussed accessing primary care and really kind of finding that primary care medical home. I am in absolute agreement with her that the best way to really provide care is to not only do the domestic exam, but to really become their long-term primary care provider, and building a sense of trust with them is really wonderful. But we also know that not everyone has that access, and there are other resources out there for them to access care. So the first one to really think about is urgent care. So this is really for kind of more minor illnesses or injuries where someone doesn't need to go to the emergency room, and very common things that you see at urgent cares. So obviously right now during the COVID pandemic, for individuals who have an infection, maybe have some mild symptoms, or they're worried about COVID, can certainly go to an urgent care to get evaluated and tested. But other common things that you can see there are musculoskeletal injuries, cuts and burns, colds, kind of more minor infections, such as maybe urinary tract infections, maybe upset stomach or ear infections. But I think it's also very important, especially when talking to parents who have young children, that sometimes the children really can't tell them what's going on. So it's really up to the parents to kind of get a sense of what their child looks like. And if they start to worry that their child just seems sluggish or lethargic, not eating as much, not urinating or going to the bathroom as much, then I'd probably pass over an urgent care and go right to the emergency room. So next slide. So as I said, emergency room care, as many of you know, is really to care for illnesses, injuries, and conditions that are much more severe. And even at times, you have to be concerned about conditions that could be life-threatening. So as we mentioned with children, when there's a change in their condition and they're not as interactive, they're not really eating, or they're not keeping stuff down if they have an upset stomach, or if they're not usually going to the bathroom, that's definitely a sign to go to the emergency room. And then I think depending on the individuals, we have people go to the emergency room regardless of their age. Certainly individuals who are more elderly or who may have a number of, say, chronic health conditions, such as diabetes or kidney disease or heart disease, they may need to go to the emergency room depending on what their symptoms are. So if someone who has heart disease or high blood pressure is developing chest pain or a racing heart, they should be going to the emergency room. They should not be going to an urgent care because you're worried that they could be having a heart attack, or symptoms of a stroke where they could have a really bad headache and potentially some weakness and slurring speech should go to the emergency room. And certainly any major injuries are something that you would see there. But on top of that, there's also cases that happen, and I'll share one in a second, where young, healthy individuals can have illnesses that you really can't predict, but you really also want to talk to your clients to let them know when to access care. So one that comes to mind is appendicitis. And one of my kind of favorite stories was a story about appendicitis in a 10-year-old child. And I'm in Philadelphia, and I work several blocks from Ariel, who works at the Nationality Services Center, and we've partnered on a number of our clients. Well, there was a 10-year-old boy in the community. He was Bhutanese, and the parents noticed that he was really pointing to his stomach, having a lot of pain, not really eating and throwing up. And they knew that he probably had to go to the hospital. And when even though they knew how to get to Jefferson, my hospital, when they started to look at all the buildings, they really weren't sure where my office was. But we had, as part of their orientation, they had learned how to get from Ariel's office, the Nationality Services Center, and walk 3 or 4 blocks to my office. So some people stayed from the community, some people stayed in front of the hospital. 1 or 2 individuals went to the Nationality Services Center to let them know that this child was sick. The Nationality Services Center called me. I was in my office. We were able to find this child, bring him into the office, evaluate him, and then we had him sent over, and he actually had a ruptured appendix. He did very, very well, but it was really incredible how the family and the community instantaneously kind of took over. And between all of them, they figured out how to get him the best care. So I think it's not only telling them and doing some education on how to call 911, but potentially, depending on what city you live in, giving some education on where hospitals are located, where urgent cares are located, because they may struggle with calling on the phone. They certainly will not, many of them will not have a car, so they need to know how they can access urgent care or emergency care. Next slide. So with respect to healthcare navigation, this has been touched on before. It's really important to also educate our clients on, once again, how to access emergency services. So being able to ask in English that they need an interpreter and be able to say what language they speak, teaching them how to call 911. And potentially, if you are a resettlement agency and you say you work exclusively with one primary care provider, potentially even educating them on how to call that doctor's office or that healthcare provider's office. As we said before, really knowing where to go and knowing when to go for what. And then just figuring out other pieces, like recognizing that individuals may need to access care for healthcare, but at the same time, they may work, there may be children that are in daycare, transportation is likely going to be an issue depending on where they are. And it's just hard to navigate the healthcare system. You know, I always say it's hard to navigate our US healthcare system if you were born in this country and English is your primary language. So trying to explain this to individuals who are not from this country, where English is not their primary language, is really challenging. So any information that you're able to provide and repeat it on a regular basis is very important. I know that Mary and myself often go over this on a regular basis with our clients, but the more we can all work together to educate them to make sure that they're able to navigate the healthcare system, they're going to do much better and have better outcomes. Next slide. So we are going back to our case. As we said before, the family is from the DRC. Emil has 2 children and his wife, as well as his elderly mother, Marie, who is diabetic. Emil, Anifa, Marie are at their initial refugee health intake with me, and they want to know, why do they have to get so much blood work and vaccines if they feel fine? So the first question that I have for you is, how would you explain to Emil, Anifa, and Marie the reason for this visit and why they need the testing done? Okay, we got requirements, building connections, prevention, excellent. It's hard to detect disease, making sure they're healthy, prevention. Disease control, absolutely. Oh, you guys get 100. This is perfect. I would say it's very interesting, as I have been doing this over the years, and I'm sure Mary could attest to this as well. So many of our individuals come from countries where they were educated to only reach out to healthcare access if they were sick. And if they felt fine, there was no need to go to the doctor. As you know, many of our clients, they may have to walk hours and hours and hours or travel miles and miles and miles to get to a healthcare provider. It is much different in the United States, how we try to do a lot of focus on prevention. So I love seeing prevention in the center as well as everything else. So we can go on to the next slide. So you've already said the most important thing is to really explain that the purpose of the testing, yes, there is a requirement for the testing. And especially when individuals have questions about vaccines, we want to give these vaccines to, one, protect them and their families. Two, we also need to give these vaccines to protect our communities, because for many of them, many of these vaccine eligible diseases, we really don't see too much in the US because of the high vaccination rates. However, in other countries where the vaccines may not be as readily available, you may see higher incidence of disease. The other thing is really talking to them about prevention and why we want to check blood tests and doing other studies to help prevent diseases from occurring or even identifying diseases. So I've met with the family, and I have found out that Marie is in need for some specialty care for her vision and diabetes. And we also need to talk about some additional testing. Anifa was referred for a pap smear and a mammogram. So one, how would you help Marie navigate the fact that she's going to need an appointment with an eye doctor? She's going to need to pick up diabetic supplies and education regarding how to administer the medication. And then for Anifa, how do you explain cancer screening? So the first question, let's talk about Marie first. How would you help her navigate these appointments? Great. Accompany her. Tell her that the appointments are important to prevent blindness. Absolutely. Diabetes is one of the leading causes of blindness in the world. Give her a note. Help her schedule, assistant scheduling, asking for translators. Support her, teach her. Wonderful. I want to hire all of you. You guys are incredible. So sticking with the slide, it is very important to get this done. And I will tell you, it is also very challenging for these individuals. I have said countless times that Mary and I and many others in Philadelphia, we would not be able to provide the care to our clients if we didn't have the partnerships in place with Ariel and many others. It is so important to have a partnership in place to make sure that we can ensure the success of our refugees resettlement, including their health. And I mean, I can think of another example where I had a patient of mine who I had ordered a mammogram. We left the visit. I went out to get lunch. I found her walking in the street, and because I told her where to go, I literally walked her to the building where the mammogram was. I signed her in at the front desk, and then I left her in the waiting room, and because I had to go back to the office to see patients, and she still didn't get the mammogram done due to some confusion. So I think the education of what they need to go, why we're getting these appointments and why they have to get it done, but also with subspecialty visits, if you're not able to have someone assist them there, you're really going to have that primary care provider reach out to those specialists so they can understand, and they may not have the same insight that the primary care doctor does in terms of what is required, making sure that language interpretation services are available, and making sure that they need to understand that this individual may need a little more tender, loving care to make sure that they get the test done. All right, next slide. So my last question, how do you explain to Anifa the importance of cancer screening and why we do it in the United States? Prevention, prevention, exactly. disease prevention. So we obviously know, and I want to make sure we can keep moving forward. Cancer prevention is so important. But for many of these individuals, cancer prevention does not occur where they're coming from. So I would not say, I think it's something that what I like to do is I like to introduce the concept of prevention, and based on the age, discuss what we're going to be doing. It is very unusual that I will get those tests done the same day. It is rare that I will do a pap smear the first time I meet a patient, unless I am concerned that there was some trauma and we need to do an examination. But it's really important to discuss prevention, discuss why we do it, and also just make sure that the healthcare provider is having a really good discussion with the patient, and together they're making a really good decision on what the patient wants. Because if you are going to be doing screening, you really want to make sure that an individual is willing to move forward with any additional evaluation or testing if some of the initial screening is negative. My last favorite story is I was explaining a colonoscopy to an Iraqi refugee, and we talked about the test of why it was important to detect colon cancer. And then I explained to him the process of taking the colonoscopy prep, coming in the hospital, getting the anesthesia, and then exactly what the colonoscopy was. And he turned to me in a straight face and said, "Dr. Marc, why do you Americans do such crazy things?" So recognize that depending on where they're coming from and how you explain it, it may seem very different because they are not used to this. So you really have to be patient to explain this. But you want them to also recognize that it is very important and we're doing it because we care. Next slide. All right, I think we're back to Ariel.
Yes, that's me. And that was a great story. Thank you. So I'm going to just kind of wrap things up with a few key points. So we've talked about key coverage options, along with U.S. health services for newcomers, so the initial screening, other health services, other education that resettlement agencies and medical providers are providing to folks. So one other key thing to think about is choosing that Medicaid MCO, managed care organization. So, because the services, the benefits that are covered can vary, these are some important considerations that are listed here. So, one is, will the client need interpretation at doctor's appointments? Because, as we previously mentioned, some MCOs do better with that than others. And do they have health concerns that will require them to see a lot of different kinds of specialists? So they, will want to make sure that there are specialists who accept that insurance that are close enough to get to, kind of thinking about those transportation challenges, other kind of, life things like childcare. Are they going to be able to get to a provider that they need to see that accepts the insurance? And then also kind of other health needs, especially dental care that, can vary what the coverage is. And, clients it may be important to them to see a family medicine provider who can see both adults and children in the family and kind of knows the whole family, or it may be important, to see a pediatric doctor who can really specialize, with the children's needs for them. And then also, considerations about language and gender, if there are options in your area, and this varies a lot in different geographic areas, but if there are options for for someone to have a provider who speaks their language, or who they can choose either a male or female provider that they feel more comfortable with, that's also important. For us in Philadelphia, our our main consideration when helping clients choose a medical or an MCO, is that we have these clinical partnerships, that we've referenced a few times in this webinar. So, and we know that in these clinical partnerships, clients are already receiving really great language access. They're working with providers who, really understand their needs and, you know, and kind of have that familiarity with working with refugee and immigrant populations. And often these provider, like refugee clinic offices are part of a larger healthcare system that does include a number of specialists. So, so in our setting, our key consideration is really, you know, geared more toward choosing that specific primary care office and provider, and then which Medicaid MCO does that office accept, along with, you know, other factors like the client's location, and, you know, where is it convenient for them to get to. Next slide, please. Other things to think about in helping clients navigate the, as we said, complex U.S. healthcare system. You know, part of your role, you know, since a lot of folks on the webinar are working at resettlement agencies, you know, part of that role is really explaining how things work, setting up realistic expectations for how long something might take or how long it might take to get an appointment for, you know, something like dental care or a specialist. It can be more of a wait, depending on, you know, kind of what's available in your area and how specific the healthcare need is. So kind of setting up those expectations, kind of setting clients up for success to know what to expect with different things, and educating newcomers on both their rights as patients and their responsibilities. So some of those rights are really partnering with their doctor. You know, in many places in the world, a doctor may be seen as having the ultimate authority, and, you know, that people shouldn't really be disagreeing with the doctor or asking questions. But, you know, in the US, we think of it as more of a partnership, and we, you know, at the resettlement agency, do try to really encourage clients to ask questions and to, you know, to actively work with their doctor to create their treatment plan and, you know, be a part of that process. And being a part of that process also is consenting to receiving treatment. So, you know, letting folks know that they have the right to agree to any medical treatment before it's given, and really to make the final decision in their own healthcare. And also access to and privacy of medical information is, you know, sometimes a pretty unfamiliar concept to newcomers. So the fact that one's health information is private and confidential, that it belongs to you, and that no one else can access it without your written consent. So that's certainly something that we explain and talk about too, and that people have the right to, you know, to get copies of their medical records. You know, another piece is access to interpretation, whether it's over the phone or in person, and that it shouldn't be at a cost to the patient. So there is a law that any organization receiving money from the government, which includes Medicaid, if someone's on Medicaid insurance, the organization is required to provide an interpreter for free to someone who does not speak English proficiently. So that means they can't say, oh, you have to bring your own interpreter, which people do say, but that's really not the process. And but it is usually very beneficial to schedule that in advance, either, if the medical office provides the interpretation, just to let them know in advance to make sure that they'll have a phone in the room if they need telephonic interpretation, just kind of those logistics. Or if you're scheduling an interpreter through the MCO, then that needs to be in advance as well, typically at least 7 days in advance. And then the last point here is, respect for the patient's own culture and healthcare traditions, and the fact that a patient has the option to choose a different doctor if they feel like their traditions aren't being respected. And also and I'll just add one more thing to this, that another thing that sometimes clients I've worked with have not really realized is that if they're offered an appointment time for their next appointment and that's not a good time for them, they can ask for a different time. So sometimes that's not necessarily a given. Next slide, please. And as far as the healthcare responsibilities, a patient's responsibilities in accessing healthcare, one of them is to ensure that the provider they're going to accepts their insurance, and scheduling appointments in advance, arriving early or on time, and if needed, canceling appointments at least 24 hours in advance. So this is something that, at National Health Service Center, my agency, we, as we're working as kind of healthcare navigators, we're talking with clients about this a lot because, this isn't necessarily how it works everywhere. And then also, as I mentioned, kind of working with the doctor in a partnership, part of that is being open, with the doctor and also, having kind of realistic expectations about what can be covered at one appointment. So there may be a lot of different things going on in someone's life related to their health, but maybe only so much that can be covered in one appointment. And patients, while they don't have necessarily the education of the doctor, they know their own bodies best. And then, another one is following the doctor's instructions or speaking up if they don't feel comfortable with them. Really kind of having that honest communication can be really important too. And it's always a good idea to advise clients to keep their own records of their medical care. So maybe keeping a folder, especially if they're going to have a lot of appointments, keeping a folder of, their medical information, their referrals, prescriptions, even receipts and bills, that can be really helpful. So those are some of the rights and responsibilities.
Thank you.
Thank you so much, Ariel. And this brings us to the end of the session, at least for the training part, and it's now time for our Q&A session. We've been receiving quite a lot of questions from you all throughout the webinar, and we hope that you've been keeping your eyes on the Q&A as well. Again, really special thanks to Sarah, Ssdi, and Clayla, who have been helping us answer the questions in the background, as well as our main speakers. Let's see, I want to open it up to you all, the speakers, to see if you saw something that stood out to you, maybe a theme that you saw over the last, 70 minutes that you may want to address. And you can just unmute. I see lots of questions in there that have been answered, so I don't want to be repetitive, but if there's maybe a final or just a theme that you saw throughout the questions, go ahead.
I was going to say, I think the theme is that it's really challenging and this is really, really hard work. But it's also probably some of the most rewarding work that you'll do. I alluded to this earlier, and I think a number of your questions discuss some of the barriers. Being able to find healthcare champions that want to work with you and being able to have a team in place, because it's not only what happens in the healthcare provider's office, it's being able to pick up prescriptions, knowing that when the bottle is empty, they have to go back and get a refill, knowing how to go to specialists. You really need a number of people because a lot of what happens with respect to their health happens outside of the office. And for many of them, by the time they get to the healthcare provider, they've already established relationships with many of your agencies. So they see you as part of the team. So being able to, I think, find a way to partner. I know it's easier said than done, but if you're able to make partnerships with healthcare teams and other community resources, you're going to do the best you can to try to minimize some of the challenges that they're going to face. And even in the best scenario, it's still really hard and you're still going to have challenges because of the way our system is designed, but you can make it a little bit easier, I think, if you have some of those partnerships.
That's a really good point. And I maybe just want to relate it to one question that just came up about someone who said, I have a problem with the doctor office, especially dentists, about them providing interpreters. I had some dentists refuse patients because they don't have an in-person interpreter. How do I inform the doctor or dentist office about how it's their responsibility to provide interpreters when they accept the patient's insurance without affecting the relationship between the client and the doctor? So I thought that was really good. I think part of that community resourcing and service mapping is really identifying some really information that might be helpful. Anyone that can take that answer, or how do you nicely and gently tell providers that it's their responsibility?
I don't have a great simple answer for that. I was just looking at that question too and thinking about it. Yeah, I mean, I think you be as tactful as you can while, you know, providing the information and I mean, I think it's a balance between really advocating where you can, and then also directing your time and energy as a resettlement agency to the providers that really want to work with newcomers and, you know, are really willing to do that. So yeah, I think some of both approaches is needed.
Thanks, Ariel.
Go ahead.
Go ahead, Blain.
At state refugee health programs, we also work with clinics and just review laws around making sure interpreters are available for clinic visits, and also provide resources for the providers on how to effectively work with interpreters. You know, part of the reason where clinicians are maybe hesitant is because they've never done it. So if we kind of coach them through the process, they tend to turn around as well.
Great. You just made the point that I was just going to say, which is sometimes pulling the laws and regulations would also push. I have one question. I think we can take one or two if it's quick, but there's one question that came up that I thought would be good to ask live. How do you discuss medical consent? For example, a sexual assault victim who may not want to consent to a pelvic exam. And I'll leave it up to the providers, unless you feel like you're an expert at it too.
Mary, do you want me to do this one or do you want to do it?
I'm fine either way, Marc. I mean,
maybe you can do with the adolescent, I'll do with the adult.
right. Okay, so I'll start with that with adolescence. I think this one is even trickier because it's not just the person who you need to get consent or you need to inform about the consent, it's the family too. And I have found sometimes in certain cultures, they can't understand why a provider would want to speak or need to speak to the child alone, because they say, I know everything about my child shares everything with me, there is no reason for me to leave the room. So I think really going through and maybe over time building trust, and I sort of couch it for adolescents that I'm doing this so that your child, your adolescent, your young adult learns how to talk for themselves about their medical issues. Because so many times they defer to the parent or the parent overtalks during a visit. I explain it that this is the time for your young adult to learn how to talk to a provider by themselves. And so that's sort of how I address it sometimes. You know, if the parent will not leave the room and the child doesn't say that they really want to talk to me alone, then sometimes it's very difficult and it may not happen at the very first visit. So sometimes, as I said, it's the building of trust and it's the education and the working. I'm not going to force anyone. I can't. But I try my best to communicate clearly and to provide information and guidance that will help them get to the best healthcare outcome, if that makes sense.
Yeah, and I would say just to add, this happens a lot. I would say probably the most common topic it happens around is usually contraception and birth control, but it still happens on a number of areas. Usually, you know, when we see the family, we try to see the family together at the very beginning to give some kind of just orientation, once again, build some trust, hear a little bit about their story of how they came here, hear about their path, because their path is going to be similar for most members of the family. But then we usually tell them, once we take that history, we are going to separate and do individual exams. And we try to have female providers with female patients and males with males. And when we separate, that's when we'll usually have our female providers let our female clients know what their rights are, because they may be coming from countries where they didn't realize they had rights, especially with regards to their health care and their choice. So we'll tell them that, you know, even though you're from this country, you're now in our country, and these are some of those rules. And so I obviously don't do that for the female providers, but on the male side, when I have families, I will also tell that to the men when I talk to them, to let them know that, you know, even though before you may have answered for your wife, here we want to give her that voice and that choice. But similar to what Mary said, you're never going to force anything, but you want to make sure that they understand what their rights are.
Great. Those are really good points that you both have shared, and I really thank you. I think that's a good one to end the session. Again, here are some of the recommended resources that were mentioned throughout the training. The full list, along with a copy of the slide deck, will be emailed to you within 24 hours. These are the learning objectives from today's training, and we hope that you can now achieve them. Before signing off, I hope you'll take a very short moment to complete our feedback survey. This survey takes less than 30 seconds, and it's incredibly helpful to us in improving our trainings going forward. And depending on how you join this webinar today, the survey itself may have already opened in your browser, and Rosalie is also dropping that link in the chat, so you can click on it and access it easily. The third option is that you can also take the QR code that you see on your screen. Again, really important for us. And finally, here's Switchboard's contact information, and I do hope that you'll stay in touch with us and join us for future trainings. Thank you so much again for joining, and a huge thanks to our speakers, panelists, and co-facilitator for all your contributions for today's training. Thank you again, and have a great rest of your day.